Hello friends, back with another session here. Here we'll discuss about diabetes in pregnancy. So let's start it. Glycosuria is normal in pregnancy, which is glucose in urine, and the fetus is completely dependent on the mother for glucose, which is transported via GLUT1 and GLUT3 receptors, which is a facilitated diffusion. So, through facilitated diffusion, the glucose is transported to the fetus. As you can see here in this diagram, if there is high blood glucose level in mother, it will brings extra glucose to baby, and this is known as Penderson hypothesis. This is known as Penderson hypothesis. Okay, and this extra glucose causes the baby to put on extra weight because fetal hypoglycemia. Okay, so fetal hypoglycemia can stimulate the fetal pancreas to produce more insulin, and this more insulin will increases the growth in the fetus, leading to macrosomia. And also this increase in insulin can lead to decreased surfactant, and this decreased surfactant can lead to respiratory distress syndrome in the fetus, in the neonate. Okay, so this is can be a consequence of hyperglycemia. Like glucose, the insulin cannot be transported into the fetus. As insulin cannot be transported, it is synthesized in fetus by itself. Because it cannot be transported, it is synthesized at 12 weeks of pregnancy. It is synthesized at 12 weeks of pregnancy, as maternal insulin cannot cross the placenta. Okay, and now in the pregnancy, there is fasting hypoglycemia and postprandial hyperglycemia. Fasting hypoglycemia and postprandial hypoglycemia. Now the insulin resistance in pregnancy. So in pregnancy, the maximum insulin resistance can be seen at 24 to 28 weeks of pregnancy, which is mainly because of HPL, human placental lactogen, but it can also be due to contributed by other hormones like estrogen, progesterone, and cortisol. So, but mainly it is due to HPL, human placental lactogen. So, pregnancy is an insulin resistant state. Now, what are the risk factors for the mother, for the pregnant lady, that can lead to GDM, that is gestational diabetes mellitus? If the lady is having a positive family history of diabetes in parents, uncle, aunts, or grandparents, or the previous birth of an overweight baby of 4 kg or more, or maybe a previous stillbirth, and on autopsy it is find out that there is pancreatic islet hyperplasia, or maybe presence of polyhydramnios or recurrent vaginal candidiasis is present in pregnancy, and persistent glycosuria. As glycosuria is normal in pregnancy, but if it is persistent, it may cause GDM. Age over 30 years, obesity is a very leading factor of GDM, and ethnic group mainly from the East Asian and Pacific Island ancestry. Okay. This image is showing some consequences and effects related to diabetes. Like the diabetes in pregnancy can is more common in a female whose BMI is over 30, and the female is at a risk of preeclampsia with a symptom of frequent thirst and frequent urination. The fetus of that pregnant female is at a risk of macrosomia, weight more than 4 kg, and a female need for insulin injection. She can get a cerebral palsy. So these are can be the consequences of diabetes in pregnancy. Now, overt diabetes. What is overt diabetes? Overt diabetes is a term when the pregnant female from the day one, her glucose level is more than normal. So the check from day one, if you get glucose level, increased blood glucose level more than normal, that means the diabetic, she is diabetic already. Diabetic female, when diabetic female conceive, it is known as overt diabetes, and there is increased chances of malformation because the increased glucose can lead to increased formation of free radicals. So free radicals can be more, and these free radicals formation can lead to increased chances of malformations. Okay, and the next thing, the test and the chances of malformation. So the test which is generally done is fasting blood glucose as a random blood HbA1c and the TIFA. First is fasting blood glucose. Fasting blood sugar is more than, when it is more than 1 or equal to 126 mg per dl. So when the fasting blood glucose is more than equal to 126, the random is more than equal to 200 and HbA1c is more than equal to 6.5%, the female is supposed to have diabetes mellitus. And the TIFA is targeted imaging. This targeted imaging is a level 2 USG, and this targeted imaging for fetal anomalies is usually done at 16 to 20 weeks of pregnancy, and this is a must done USG. If the female demands that she can only go for one USG in entire pregnancy, ask her to do the USG at 16 to 20 weeks. Okay, and this is done in both. In both means in over diabetes and gestational diabetes, in both. Okay, chances of malformations when depends on HbA1c percentage. Like there's no HbA1c percentage, no chances when the HbA1c is 6.5%. It is less than 6.5%. 5% chances when it is between 6.5 to 9.5, and but it is more than 9.5 percentage, then the chances of malformations are 20%. So the question arises how to manage these over diabetic female. We should strictly have a glucose control, and these glucose control can be self-monitored via capillary blood glucose goals. Okay, and these goals to be set at, like fasting blood glucose should be kept less than 95 mg per dl, and 1 hour postprandial it should be kept at less than 140, 2 are less than 120, and HbA1c value should be kept at less than less than equal to 6.5%. And folic acid supplementation is must for the females of overt diabetes, as the organogenesis is there in the first trimester, and there is increased chances of malformation at that time. So it is given in the therapeutic doses, like folic acid is given in the 4 mg per day. Other indications where folic acid is supplemented as a therapeutic doses in a therapeutic doses is in the neural tube defect risk, in the sickle cell anemia, in a diabetic female, and in case when a female is on anti-epileptic drugs, especially the valproic acid. Okay, and the valproic acid, and it is given in the dose of 4 mg per day. Okay, so the drug of choice for the female of overt diabetes is insulin. Insulin is given in the overt diabetes female as well as gestational uh, diabetic mother also. Okay, and since it does not cross placenta, it should be supplemented from outside, and all the oral hypoglycemic agents are contraindicated in pregnancy, as it can cross placenta and fetal hypoglycemia can occur. But the only hypoglycemic agent which are to be given are metformin and glyburide. But the preferred most drug is insulin. But in cases where the female not want insulin, we can provide her metformin, or there are some situations where insulin cannot be given, then metformin and glyburide can be preferred. But over in between both of them, the glyburide is preferred over metformin. So Over metformin, the glyburide is preferred mostly because the metformin has having some side effects like a GI upset. It can have a GI upset, or the most dangerous side effect of it is lactic acidosis. The most dangerous is lactic acidosis, but it is not teratogenic. So it can be used, but it is not preferred over glyburide. Even glyburide is more preferred than metformin. Okay, so glyburide is more preferred over this. Okay, so coming to the next slide, some facts regarding diabetes. The heart defects. Most common system to be involved in these congenital malformations seen in babies of diabetic mother, and the most common system to be involved here is heart. And in the heart, the most common congenital malformation which can occur is VSD, and the least common is TOF, and the most specific cardiovascular anomaly can be TGA, and the most common finding between them in them is can be HOCM is hypertrophic, and the most specific one is caudal regression, which is a sacral agenesis. Sacral agenesis. So the most specific serious finding is TGA, serious disease is TGA, that is transposition of greater arteries, and the most specific overall is caudal regression. As most common system involved is CVS over CNS. But if we will talk about some specific thing, then caudal regression is a more specific congenital malformation to occur. Now, the diabetes occurring in a previously normoglycemic female, it is due to insulin resistance, which is maximum at 24 to 28 weeks. So the glucose is maximum at 24 to 28 weeks or after, and thus the organogenesis is already there. Okay, the organs are already formed, the limbs are already formed, organogenesis is already there. So there is least chances, and there are no chances of malformations here. Now, so the point we have to remember here is that any degree of insulin resistance, insulin tolerance diagnosed for the first time during pregnancy, irrespective of gestational age and parity, is included in gestational test. Tests are diagnostic methods for diagnosis of diabetes in pregnancy. It can be a one-step approach, it can be a two-step approach. Two-step approach is given by ACOG, and a one-step approach is given by DIPSI in India, where no fasting is to be done, and the glucose is given the 75-gram dose. So one-step approach is a directly a diagnostic method. It is directly a diagnostic one, and the two-step approach is the first of a step is screening, and the second step is a diagnostic one. So in the first step, the selective screening can be done, or universal screening can be done in the areas where diabetes is not prevalent. They're only a selective. So diabetes not prevalent, there only we will do a selective screening. We'll do a selective screening. Okay, and in the areas where the diabetes is prevalent, so at the time of 24 to 28 weeks, the universal screening is to be carried out. In the high risk females, in the females who are at higher risk, there at the first antenatal visit, the test should be performed. If it is normal, it should be repeated again at 24 to 28 weeks. And those females who are at a higher risk are So the females who are at higher risk are those females who are at a family having the family history or the previous history of GDM, or they are, if they are obese, age more than 30 years, previous history of a baby with the 4 kg of or more weight, previous history of abortions, stillbirth, in which the autopsy declared and autopsy cleared that it is a pancreatic islet hyperplasia, and in the present pregnancy if there is any complication related to diabetes or there is polyhydramnios. Okay, and the Asian population, mainly the Indian population, is at the risk of diabetes because India is a diabetes capital of the world. Okay, so in these high risk females, always note that we have to done the test. Okay, so first coming to two-step approach, ACOG has given the two-step approach in which the first step is a screening test. It is a glucose challenge test where the no fasting is needed and can be done at 24 to 28 weeks. Irrespective of the previous meals, the female is given a 50 gram of glucose, and after 1 hour check the blood sugar, check out the blood sugar of female. Okay, so we need to check out the blood sugar of female. Taking the blank slide, so the if when you check the blood sugar and you get less than 140 mg per dl, there is no chance of malformations, and between 140 to 180, if you it is there, then it is maybe the female is diabetic, and it is if more than equal to 180 mg per dl, the diabetes is confirmed and there is no need for second step, then second step is not needed. It is already confirmed that female is diabetic, and in this female we should again go for glucose tolerance test, which is a second step. Here the female is asked to do overnight fasting, and after fasting the female is asked to come after approximately 8 to 10 hours, and then we'll give the female 100 grams of glucose, and then we have to first measure the fasting blood sugar, and after giving 100 grams of glucose we'll take our second sample, then third sample, and then the fourth sample. Second sample should be taken 1 hour postprandial, then 2 hours postprandial, and then 3 hour postprandial. Okay, total 4 samples are to be taken, and if any two or more samples are abnormal, the diabetes is confirmed. Okay, so the value which we are hoping to get for the female to be diabetic is, for the fasting blood sugar it should be more than 95, but in according to India national diabetes criteria, it should be more than 105 mg per dl. So we'll take another blank slide. So I have already, as I have already said, that fasting blood sugar, and then first hour postprandial, then 2 hour, and then 3 hour pp postprandial. The fasting blood sugar, according to the national diabetes criteria, according to Indian criteria, the fasting blood sugar should be 105 mg per dl or less. If it is not, then the female is diabetic. The first 1 hour, 2 hour, and 3 hour, 1 hour is more than equal to 90. The female can be diabetic, definitely diabetic, and 165 2 hour and 145 after 3 hour, then it is a criteria to say that female is diabetic. Now the one step approach. So the one step approach is, the female is, it is an only a screening test in which we will do a 2 hour 75 grams oral glucose tolerance test, in which the female is asked to do overnight fasting directly at 24 to 28 weeks. Will ask the patient to do overnight fasting, and then the first sample is taken of the fasting blood sugar, and then after 2 hours for the first hour pp, and then after second hour pp postprandial will check out the glucose level, and if one or more than one is abnormal, the female is said to having a diabetic. Okay, now the fasting blood sugar should be more than 92. The first hour is more than 180 and the second hour should be more than 153 to say that the female is diabetic.